All right, everyone, good morning. How are you doing today? Welcome to the ongoing series of CareOregon's Pharmacy Department, quote-unquote, continuing ed series that we have on different medical states and their relationship to pharmacology. How appropriate is it that on the day we're handling depression, for the first time in about 3 months, we get it to rain in Portland? What I had to go through to make that happen, I'm not willing to share, but I owe a few favors for folks. We always seem, you guys are a pretty lively, interactive group every time you come and join us here. Everyone feel willing to share a little bit to start things off? How many of you are willing to admit that within the last week, you had a bad day? Whoa! Pretty unanimous. For those of you who didn't raise your hand, in the last month, did you have a bad day? Yeah, pretty common deal, right? We all kind of feel that that's something that it's okay to share when, things kind of go south and, somebody cuts you off in traffic or whatever it may be. It's okay to have one, right? You're not going to get in trouble. But imagine, if you will, what's it going to be like if it seems that every day it's like Groundhog Day with your bad days. They just keep coming over and over. And it feels like there's this cloud chasing you that's repeating itself, and you can't seem to get out from under that. And it's not something you seem to be able to control. That's kind of what we're talking about here today. And also, what if having a bad day, like we just admitted to, what if there was such a stigma associated to having a bad day and to feeling sad about things that you couldn't really confide in your peers or loved ones that you were going through that? You couldn't really admit at work, gosh, I had a bad day, because of the stigma and sense of, wow, I'm going to be shunned by people if I admit that. So just something worth considering here, because when you look at how depression affects people, we have nearly 20 million people in this country that are affected by depression in one way or another. Unfortunately, there's 41,000 or more people per year that are so affected by it that they feel they have no other choice but to take their own lives. So it's a dramatic factor that we're going to hopefully be able to look at today in a way that we can provide some positive strategies to help cope with here, because there are positive strategies that can make a huge difference for people. When you take a look at some of the statistics up here, especially involving situations for suicide and the prevalence for folks that are younger, those are some pretty sobering numbers up there in terms of what that will do if somebody's unemployed for a long period of time, longer than 6 months, because our self-esteem is pretty much tied up to what we do for a living, I think, to a huge degree. And so if you're not able to make a living, that can really undermine your sense of self in a strong and terrible way. We do have within our network of CCOs, it's a metric also for depression screening, and ideally that there is follow-up there, and you can take a look in the second bullet here and you can see the percentage of our members that have a positive depression screening that do receive a follow-up plan. So we'll hopefully be learning a little bit more about that today as well, but it is definitely a metric and something that we should keep in mind. So let's see if we can get some beams of sun through the clouds here this morning and start dealing with this topic. For the first half of our presentation, we're going to be doing kind of an intro to psychology and psychiatry. We're going to be focusing on the patient perspective. What's it like to have gone through treatment for depression? Because you certainly can with tremendously successful results. And we're going to talk about assessment and making a plan to cope with that as well. To lead us through the first part of our presentation this morning, we are incredibly fortunate to have the Psychiatric Medical Director from Old Town Recovery Center, John Bischoff from Central City Concern. He is a fantastic guy, and we are very, very fortunate to have him with us here today. Please give a warm welcome to John Bischoff. Thank you.
Well, thank you, Paul. I hope I can muster that much enthusiasm for what is actually a really serious topic. But so yeah, I'm John Bischoff. I'm a psychiatrist, practicing psychiatrist. I do 20 hours a week of direct clinical care at Old Town Recovery Center. And I'm the Psychiatric Medical Director. So yeah, I have a career in public psychiatry, about mostly behind me at this point. And I trained at OHSU, just to give you some details. I've worked all throughout the public system in Oregon. And I do want to tell you too, just to establish my credentials with you, that nurses are my favorite people. I hope you believe me. And I'll tell you why you should believe me, because earlier this morning I called my ex-sister-in-law, who is like a sister to me. And when I was 6 years old, she was preparing to go to nursing school. And I looked at her nursing textbooks with just wide-eyed wonder. And it was the beginning of my interest in life sciences and in medical science. And so I called her this morning to tell her I was going to be talking to, is everyone a nurse? Right? Everyone, yeah. So I was going to be talking to a group of nurses. She was really pleased, and we caught up, and it was wonderful. So. Yeah, and actually my first physician mentor when I was 16 years old, a friend of mine, her mother was an ER physician. And she invited me to spend the summer at night. She did night shifts, right, so she could take care of her family during the day, with her in the emergency room. And the first night I showed up, she said, "I bet you're really excited." I said, "I am." And she said, "Yeah, I bet you think it's going to be you and me and doctor stuff all summer." And I said, "Yes." And she said, "No. You're going to follow the nurses, you're going to work for the nurses, and you're going to learn that if and when you become a physician, the most important person in your professional life will be a nurse or nurses." And she was right, obviously, right? So, and I really put that into practice. I teach the students who I work with and the residents who I work with that is a really important aspect of being a successful healthcare provider in general. So. Anyway, I'm glad you're here. I'm glad you're interested in learning more about depression today. And we're going to get rolling. I want you to know, and this is a part of the take-home, right? Depression is incredibly common. Paul already shared with you how common it is. The numbers are pretty staggering. Actually, in the US and also internationally, it's really a heavy disease burden in terms of human suffering, human lives, and financial cost. And you, as a primary care nurse, most everybody's primary care nurse, is that right? You're in a unique position to screen for it, to identify it, and to refer people for help. Maybe you've already done that. And I love this quote that I think Paul came up with, or someone came up with, right? Save one life, you're a hero. Save 100 lives, you're a nurse. And that's why we do what we do, right? So yeah, we're going to start out with just a brief review of Psychiatry 101, I call it. And by the way, I thought it was interesting that psychology in the little sort of schematic about what we're going to talk about today got left in there, Psychology 101. Frequently confused. In fact, you know what? Before I did my psychiatry rotation as a medical student, I had no idea what a psychiatrist was. I would have confused the two as well. So it's pretty common. Does anybody know the difference between a psychologist and a psychiatrist? Yeah?
Psychiatrist is a medical doctor.
Right, psychiatrists are physicians.
And psychologists have a PhD.
Psychologists have a PhD, right, yeah. We work together really collaboratively in great ways. And psychologists have really great skill to bring to testing, help with diagnostic clarification, with sort of really stratification of cognitive impairment. And also they tend to get better education in terms of clinical therapies. But yeah, psychiatrists prescribe medications. They collaborate with primary care and other medical specialties on the whole care of a person. So, severe mental illness or serious mental illness, the two terms are used interchangeably. We used to say severe and persistent mental illness. We don't say persistent anymore. And before that, actually, we said chronic mental illness. Who remembers CMI? Anybody remember that? Yeah. So we don't say chronic or persistent anymore because the fact is people can and do recover from very severe mental illness, including schizophrenia. We have treatment technologies today that allow us to say that with confidence and to back it up with data. So the formal definition is that it's of sufficient duration to meet DSM-5 criteria. It results in serious functional impairment or which interferes with a person's major life activities. You'll also see in the disorder definition that it includes clinically significant distress. That's the formal. In practice, the severe mental illness that we deal with, by definition, everyone by contract at the Old Town Recovery Center has severe mental illness. These are the major diagnoses that we deal with: schizophrenia, bipolar disorder, major depression, post-traumatic stress disorder, trauma, incredibly common, right, in public sector folks who we serve. Generalized anxiety, obsessive compulsive disorder, among others, but those are the major the major diagnoses. So it's all about integrated treatment these days, right? Does everyone know that? Health reform, it's all about integrated. We've been working in mental health, behavioral health, at integrating with substance use disorders for a very long time, trying to knit together, right? And what's the reason why they're separate? Anybody know why? Insurance, money, right. The pots of money are separate still, actually, although that's about to change here in Multnomah County. So anyhow, we also recognize that people with severe behavioral health problems, and that includes mental health and substance use disorders and/or, right, usually have a big history of trauma. So I know that you all have heard about the ACEs study. Everyone know about it? Been to the website, read about it, fascinating study. Showed a direct linear correlation between chronic health problems and the number of adverse childhood experiences you endorse, right? And when I say you, I mean us. It was a study done by Kaiser on people just like you and me, right? It wasn't even on the population that we serve in public health, right? So also substance use, obviously, we integrate recovery. And we have broadened the term recovery to include not just substance use disorders, but behavioral health disorders generally, and also integrated physical health, right? I have the great good fortune of, for the last almost 3 years, working at Central City Concern, Old Town Recovery Center, co-located with really one of the finest primary care services in the country. It was recognized as one of 30 exemplary primary care services, the Old Town Clinic. And some of the folks who work there are here today. So it's all about integration, but when I first arrived there, they had moved in together. How long had it been? Maybe about a year or so. So the primary care clinic with the behavioral health clinic, they'd moved in together before I got there. And there was this integration cloud kind of hanging over the clinic. And there have, especially the leadership that I was interacting with, they were like, how can we integrate? How can we integrate? I said, well, first off, let's stop talking about it, right? Because it puts this burden on people. And secondly, when we start talking about it again, let's emphasize that it's a goal. Integration is a goal. You don't just magically integrate, especially even if you move in together in the same building, right? So we had to recognize the formal ways in which we were coordinating at Old Town Clinic and the primary care and the specialty behavioral health. We actually respond each to the other for emergencies, right? That's a formal way. We have a written policy and procedure that tells us how to do that. So and then we have lots of informal collaboration, right? We just pick up the phone, or what I love is I can just walk down the hall and go talk to my colleagues, right? And sometimes I probably bug them too much, but it's really amazing. And integration is a goal. So I want to say a word about stigma, because stigma, although it's getting better, the stigmatization of people with severe mental health and or substance use disorders persists, right? It's public. There are still stigmatizing images in the media, right? In movies, although that's changing. I'm glad to say that not every mental health professional, not every psychiatrist that you see in a movie is a cannibal anymore. Not every person with severe mental illness is a deranged killer, right? They actually, about how long ago was it? We depicted a Nobel Prize winning economist, right? A beautiful mind. So, but it's also personal, right? We take these images that we see and we internalize them. And if we have severe mental illness, actually it becomes sort of a self-stigmatization, right? And actually, I should admit that even though I've been a practicing psychiatrist, right, for 20 plus years, I still have moments where I have these kind of thoughts, these attitudes and behaviors, right? So what do we do? Because it's damaging to people, right? It limits access to services, health services, behavioral health services. It limits access to housing. Sometimes people are discriminated against based on it, right? And increasingly in this country, where are the mentally ill treated? The behaviorally disturbed people treated? In jails and prisons, right? The criminalization of the mentally ill is a known phenomenon, is well documented now, right? And we could talk probably all the rest of the day about that, but we won't. It's damaging. The good news is it's changeable, right? There's a really excellent research consortium led by this fellow Corrigan in Chicago. They do nothing but research stigmatization of mentally ill people and how to change it. And their fundamental sort of findings, more than a decade ago now, were that protests, which I kind of just did a little bit, you heard me sort of say, these stigmatizing images in the media, and actually, frankly, I've called CNN before and said, hey, wait a minute, this person used the term crazy to describe a person with a mental illness. It helps, but there's this big risk that you're going to get rebound. People are going to say, they threw this in my face, and those mentally ill people, or those psychiatrists, that psychiatrist from Portland, Oregon. So it's not really effective. Education, which we could do here today, right? I could just tell you, please don't discriminate against people with mental illness. They're just like you and me. Maybe you have a family member, maybe you have, maybe you yourself, that kind of thing. It helps, but it's not sustained. It's not a sustained effect on attitudes and behaviors towards people with mental illness. The only sure way that CareOregon and company determined that changes people's thoughts, their hearts, their attitudes and behaviors towards people with severe behavioral health problems is contact. Having direct face-to-face contact with a person who puts a human face on what it means to deal with behavioral health issues. And though they found too that there had to be what's called a high degree of disconfirmation of stereotype. Just means that the person makes you pause and say, oh wow, that could be me, or that could be my brother, that could be my cousin, that could be a colleague, right? So for that purpose, and with great gratitude, I want to introduce David Lee Greenlee, who will bring the personal perspective, the recovery, first-person perspective. Please give David a warm welcome. Thanks, everyone.
So my name's David, and it is my honor to be here today. I was very excited when Paul and John gave me the opportunity to come do this. One of the very first things that I want to say is how grateful I am, because doing this benefits me just as much as it does you. So I'm going to kind of share my personal story with you as it pertains to depression and recovery. Share some processes and some experiences that I had when just starting out, initial diagnoses through childhood and on to military service, and then we're going to talk about what changed when I finally sought out the treatment I needed. So I'm 38. Never been married. I basically been diagnosed with depression since the age of 8. Was some school issues, insomnia, acting out, nightmares, and that resulted in me being taken outside of the school to a private psychiatrist who diagnosed me with attention deficit disorder and major depressive disorder. I went on medication for the first time in my life, and right around age 12 or 13, I learned that the medication that I was on could be abused. I was stimulant medication for the ADD. So that was my first introduction to being able to self-medicate. Fortunately for me, that was a very short-lived event, and I was able to move on with my life without having that catastrophically affect me. So let me just get my glasses out here. So there is something ironic about the date today, being the 28th. 2 years ago, this morning, I have to check the time, but sometime before 8 o'clock, I was waking up with a set of oversized scrubs on as a guest at Providence St. Vincent in the behavioral health unit. One of the CNAs informed me that I had a phone call this morning, and it was from my caseworker at CCC. And it was one of those moments in my life that absolutely told me that even if I wanted to be alone, I couldn't be. I'm gonna take you through like maybe some barriers to the treatments and the stigmas that I had. A lot of the stuff John touched on just basically applied to a personal experience and through my own viewpoint. And my hope in the end is just that you can find something, anything that you can relate to, or anything that just catches your attention that you can use in your practice to further advance nursing and as it applies to mental health. So the comorbid diagnoses I have are complex post-traumatic stress disorder, adult ADHD, and bulimia nervosa. Those are all active. Those are all currently symptomatic. Those are all things I'm currently being treated for. And I'm currently very, very, very happy with the progress being made. Something that I was deciding whether or not to do. I also have a cluster B personality disorder, which is something that goes hand in hand with the word stigma. It's something that not but maybe 10 years ago, I would have had a problem finding a psychiatrist willing to treat me because of the problems that people can become and the problems that they bring to a treatment team, and the resources that they can end up using. So my family history, my biological father suffered from cocaine-induced psychosis throughout most of his life. I do have a history of suicide in my family. My dad killed himself 3 years ago. And my Aunt Marie did when I was very young. My sister has complex PTSD and major depression, on top of a substance abuse problem. So just to tell you what happened to me, after the diagnosis, I was stuck basically having to deal with it on the family level at first. This is when a very formative point in anybody's life, between the ages of 10 and 18. I mean, this is when we're learning how to function in society, we're learning the social contract, and during that time, I was hidden away by my family. My family treated me as if I was taught secrecy from a very young age. That went kind of hand in hand with what John mentioned about self-stigma. I was taught stigma from a very early age that what I had was something wrong with me, and that if I shared that with somebody, it would make not only me look bad, but my family look bad. And that was something that I carried with me through high school. And then, on top of the insisting on secrecy, I was adopted out after age 12, and my adoptive parents were both in recovery from alcoholism, and they were 12-step Alcoholic Anonymous people. So I was exposed to that sort of treatment very early on. Unfortunately, some of the problems I was having, I was seeing some conflicts inside of that as it pertained to mental health. The 12-step program works wonderfully, and it saved a lot of my friends. I have friends that would be dead without those programs. But when I'm dealing with something, say like bulimia, where I can't just walk away like I can from a drug or alcohol and never do it again. Abstinence works for that. It doesn't for eating. I have to eat. I have to be in a relationship, though I have codependency issues. So it made me look at this a little differently. Abstinence was no longer an answer for me. I could not just do the 12-step route. I needed something to teach me to moderate, to teach me to be able to handle the cravings without giving in and going overboard. So at this point in time, I started to do my own research, and I started to do my own, maybe even a little experimentation around what caused certain moods, what would cause certain behaviors, what triggers were. And the one thing I noticed is that between the depression, the suicidal ideation that came with it, and any substance that I was self-medicating with, they all are interdependent upon each other. All of them, the eating disorder. I mean, I know that the biology behind it, you all know. We all know the dopamine system and the reward pathway and all that stuff. But there's something more to that. Just if one can exacerbate another, the eating disorder can make the depression worse, or the depression can make the eating disorder unbelievable, and they can get caught into a cycle where one will make the other worse, and I will do one thing to get relief from another thing. So comorbidity is a really, really hard thing to deal with. Unfortunately, there's a really high rate of that in depression and personality disorders. Both of them are, I think it's much more likely to have some sort of comorbid diagnosis than not. So, so during this formative time, late high school, my peers are still learning in a normal way how to deal with their emotions and how to deal with the social contract and learning. So I'm not getting a whole lot of empathy there. It's not that they don't have it, or that they don't possess the ability to use it. It's that they're not skilled enough to be able to express that in a way that doesn't come across as condescending or bullying in a lot of ways, because we're alpha males. You know, that's what my friends do behind closed doors. And of course, my learning with the stigma to grow it up is, or with the way I grew up with the stigma, it's just to laugh it off. And truthfully, that's every time it happened, I would withdraw further from my social life. The close friends that I had that knew that I would tell that I have a mental health issue, they got frustrated after a year or two, because depression is hard on a person's family and friends. The thing that we know that we need to do the most is often the very hardest thing for us to do, is to get up and get some momentum going. And it's that thing when you're laying in bed in that dark, lonely place, and you know one thing will help you, and it's the hardest thing in the world. Your mind is just telling you you can't do it. And that ends up with a big feeling of hopelessness. I've often said that Sisyphus is my hero. I wake up every day to the same thing, nothing changing, and then there are some existential things that came into it, and that's when things started to get dangerous. I started to get suicidal ideations, and it's about this time that I thought joining the Army would be a really good idea. I tell you, that's joining the Army with any sort of mental health disorder. I'm going to go ahead and say that's not a good idea. I know that there are people that'll tell you have to have a mental disorder to join the Army. I'm not one of them. I joined up when I was 23, so I was a little older than the average person. I wasn't able to be indoctrinated. I was much more able to maintain my own personality going through the training and things like that. But there is the ultimate form of stigmatism in the military. I never got to experience it because of the fear around triggering it. There is a huge culture of fear amongst soldiers for seeking anything like that out. And I've got a long list here of reasons, but in a type A environment, there's the culture from day one of stoicism. I mean, we're expected to be soldiers. We're expected to suck it up. And that's, I mean, you don't even need to be in the military to know that that's an alpha type behavior. But in a small, 60-man unit, oh yeah. The number one fear is letting your team down. It's not about getting caught. It's not about hurting yourself. The number one fear you have is that once you realize that there is something wrong with you, that you're different in some way, that will somehow cause you to fail your team. And that'll cause somebody to not come home, or to come home in a very bad way. At this time, some of the peers might actually start to be empathetic, because they've gone through combat, they've gone through some things, and they have now reached a point where they've been through what you've been through. So they can see where small triggers, small signs, like somebody's sleeping too much, somebody whose eating habits have changed. When you sleep next to somebody for 9 months, you get to know them. So while some of those peers will encourage you to seek help, some won't. Some will, really berate you and belittle you. Unfortunately, that does happen in this day and age. Alpha male environment. So some of the fears are just having to talk to the head doc, being judged as weak or malingering. In my case, I was really afraid of losing my security clearance. And the likely end, which was a Chapter 5 discharge. It's basically an administrative discharge. While I was still kind of moving into when I got out, I was really using some unhealthy coping mechanisms. There comes a point in time where you kind of accept that you have this, but you have no idea what to do with it. You have no idea how to deal with it. So it's like, what did I say to somebody the other day? It's like a drunk baby with a shotgun. There's just no way it's going to end well. Drugs, alcohol, I mean, bad relationships, you name it. I made some sort of an attempt to fill that depressive hole with whatever I could throw into it. And as you can imagine, it only made things worse. It's throwing gasoline on the fire. I had a very, very great nurse practitioner one day tell me that taking my sertraline while drinking was like spitting in the ocean. I thought that was a great analogy. So, risky behaviors started happening, reckless driving, fighting, getting into abusive relationships. There's kind of, it's like this, as it says there, like a spin that you get into and it's hard to get out of. So it's a self-destructive cycle. And that resulted in a suicide attempt for me. I cut my wrists and was found by some squad mates unconscious. And I was able to go inpatient at an Army facility in Oklahoma called Taliaferro, Behavioral Institute or Center or something. And I was kept there basically until I was chaptered out, which is the Army's nice way of saying get out. We're not giving you benefits. After I got out, I was promoted to civilian. I basically just drifted. I was homeless in Detroit for about 2 years. I'm from Detroit. So I went back home and just drifted. Homeless here is not the same as homeless on the East Coast or in the Midwest. It's not. Homeless in the Midwest means there's a chance you're gonna die. You're gonna freeze to death. We lose a few people every year. We don't have 1% of the services that Portland has. I mean, I saw things that happened here, CCC, like to this day, I'll see things CCC will do and I'll be like, really? Like what? And it's always amazing. So I had met a girl a few years into the Army that I spent time with during my homelessness. Unfortunately, she was finishing graduate school right then and basically just broke under having to help me at the same time seek out treatment because I had nowhere to sleep, I had nowhere to eat, and I still had never had a single encounter with social services. And that changed with her the day I walked into Salvation Army. And that was my first interaction with any medical professionals. They had a nurse who came out and sat with me. I can't even imagine how long it had been since I'd seen a doctor or a nurse. So they helped me get back on medication. And I use what resources, the same things you see here, community college, gymnasium, just resourcefulness that people on the street use. And I was able to save up about $1,000 and I came to Oregon, chase a girl, oldest story in the world. And I fell in love with Oregon. The relationship didn't last, but I did. I loved it here, and I didn't leave. So during that time, I met somebody, and we were together for about 1.5 years. And she had an overdose Christmas Eve. This will be 3 years coming up. And that put me basically back. That was my excuse for allowing myself to rationalize not continuing treatment and going into a downward spiral of self-medication. I had 8 admissions in the last 2 years. 12 ER visits, 8 admits to the behavioral health unit between OHSU, Providence, St. Vincent, and Good Samaritan. So I walked into Hooper Detox for the second time. The first time was as an intern. I'm an EMT, so part of getting your EMT license is that you have to do a 12-hour rotation in some sort of behavioral health, anything. And where I went to school, Hooper was the place. Everybody went to Hooper. So for the second time, I went in as a client this time. And I was in really bad shape and I didn't know what to do. And for the first time ever, I was just defeated. I didn't care what happened to me anymore. They could have just said, we're gonna throw you in a wood chipper. I've been, sweet, just get it over with. I realized that the practitioners that I was dealing with on a day-to-day basis now, from I was being inpatient at Hooper Detox and on into outpatient therapy, they were not doing this job for money. They did this because they actually believed in what they were doing. And that, to me, just seemed like a foreign concept. So I went through A&D counseling for a year in the old building across the street from the Old Town Recovery Center. It's the CCRC, I think it's called. And I went through that program with Kelly Fitzpatrick. And they got me into housing in like days. They made phone calls, they knew the situation I was in, and having been sober for 10 days without any symptoms of depression, they knew it was a critical time, that housing is healthcare, basically. It wasn't easy. You know, I had to stay in a shelter first, and from the shelter to a dorm, from the dorm to a program apartment where I was expected to drop UAs every day, and you earn that trust every day you're there. Now I live up in a permanent apartment I have for going on 3 years this November. And that's because of a housing advocate I had. Medina Kearney. And I'm gonna give you just a little look at what it's like to be marginalized here. I know sometimes it can be hard. I've dealt with it myself as an EMT when you're dealing with frequent flyers. That you hear the same story day in, day out, day in, day out. And it gets really, really hard. The problem is that maybe 1 out of those 10 times it's true, and we dismiss that. My voice got lost in it when I was supposed to be getting permanent housing. There was some issues going on behind the scenes that I was unaware of. And I was taken off the housing list and basically told to screw off. That I was gonna be punished for something somebody else did. That there was a little war going on, and this seems so surreal to me. Like I didn't believe that actually would happen. That can't happen to somebody. There's some responsibility or something. I've done something wrong. I didn't. And because of that, my housing advocate went to war. She put her job on the line to get me into housing, to get me into a permanent apartment. And that's been my experience with Central City Concern, is that they have no problem when they know that it's the right thing to do, when they know that they're gonna make a difference in somebody's life, that they're willing to go out and really advocate. And that's taught me to do the same, which is really nice, because that allows me to be like a force multiplier, because I have them advocating for me while I'm now doing that for myself. So after that, there was the 2-year string where things were just out of control. It was the most symptomatic I've ever been. It's the most string of hospitalizations I've ever had. Substance abuse had a large amount to do with it. Alcohol exacerbates depression. Pause for effect. Alcohol, it's like a special thing. We know any sort of drug exacerbates any sort of mental health condition. Those two have a special relationship. And every single time I was admitted, I was very intoxicated. Every single time that I was willing to put forth any serious effort into taking my own life, I had to get intoxicated first. Which brings me to one of the points that I wrote down here for a hope I have for perhaps further on in your practices, is it's easy to dismiss somebody because, again, we've seen it day in and day out, and it's just, we're used to it. But to share a story, I had a patient one day that was presenting altered mental status. You could smell alcohol in their breath. I mean, from 10 feet away, I could tell what this guy's problem was. So I was the junior EMT. We loaded him up, and it's a good thing I checked his blood sugar halfway there. This guy was not drunk. He was in a diabetic emergency, and I almost missed that because I was willing to dismiss this guy as drunk. So I have been in the ER before. 0.38 blood alcohol level. I was in trauma ICU unit at OHSU. Lost about 3 days. And I'm sorry. It's yeah. I'm gonna move on. Sorry. So where I'm at now, what turned all that stuff around was the iHeart team. There's a team at Central City Concern that was recently recreated or recently reformed, and it seems to me, because I've been there for a few years now and I've watched these changes as they've taken place and kind of been fiddled with, and it's just a constant improvement to see the trainings that are constantly happening, and that gives me hope for future outcomes for depression and things like that. The way that they allocate their resources is really impressive. Sometimes seeing them do so much with so little. So my hope in closing would be that I really, really hope that you guys can see a way to have empathy for the patient as you're going through triage or as you're going through any sort of mental health assessment. If this person's intoxicated, be careful. There could be something else happening. They could very well be willing to take their own lives. In fact, there's a high rate of people that are intoxicated when they commit suicide. It's one of those things that lowers inhibitions, obviously. So if you ask the right questions, or if you're willing to wait till they sober up, sometimes you can get the right answer. That one can be difficult because I've been on both sides of it. I've been the combative patient, and I've been the EMT who got punched in the stomach. Don't argue with a drunk. You can't argue with somebody when they're intoxicated. It's pointless. It's like trying to teach a dog physics. But if you wait until they, it's the truth. But if you wait till they sober up, you might be surprised that this person's very receptive into receiving services, into hearing out what it is that the provider has to say, because it can be really difficult after you've gone through the process of allocating resources, sharing it with this person, just to know that this person is going to walk out the door and not use them. And that's another thing that it causes some of the resources to run dry. So anyway, I think that's just about enough from me. I guess one of the things I did bring with me here is a little closing here, is that I know that one of the reasons they asked me to come here was that I guess I kind of am like a Joe everybody. That I'm remarkably unremarkable. I have, a basic associate's degree in criminal justice. I'm currently attending nursing school. So that's that was the little surprise for the end. And yeah, I'm in my second year taking on prereqs in a two-year program, BSN program, OHSU. So I could be one of you. I could be working right next to you. I could be your brother. I could be your dad. I could be your son. So no matter how combative and evil and spitting and whatever the horror, just awful things come out of our mouth, we're still sick. We're still very sick. In fact, when we're that way, we're the sickest you'll probably ever see us. So, I want to end on a good note. So, to give you an idea of where I am right now. I wrote this to my healthcare provider, my doctor, my psychiatrist, actually, on April 15th of this year. It just was after a moment of self-reflection. I had sat and thought about progress. And so anyway, it says, Dr. Bischoff, the only thing that's worse than my ability to write this kind of letter is my handwriting. So I decided to type this instead of forcing you to read my chicken scratch. Though a doctor having to decipher a future nurse's handwriting is all kinds of funny. So when I came to be your patient, I was without a doubt in a very bad place. If you had asked me then, I would have expressed how little hope I had for the future and how futile I thought any future treatment would be. It was only solidified by the recent suggestion that I was showing symptoms of borderline personality disorder and antisocial personality disorder and histrionic. I was starting to show some really scary stuff. I'm sorry, let me rephrase that. I was starting to notice that I had been showing some very scary stuff for a long time. And I had a maladaptive way of coping with everything. And it does have a lot to do with what the childhood, I think it was called ACE, and the trauma model is definitely spot on. But to continue here. This was only solidified by the suggestion that I was showing symptoms of BPD and the terrifying thought that I might be a psychopath due to the lack of empathy that I felt. With the guidance of him and Alana Kaufman, my therapist, I've come to understand that not only am I not a psychopath, but I'm a pretty good person that cares about other people. What happened was I had learned to disassociate as a coping mechanism for trauma. So the past 6 months have been the largest period of growth I've had in memory. From things as mundane as sleeping through the night to returning to school and achieving a 4.0. The changes are undeniable. Above all else, I have a renewed feeling of hope and faith. When I relapsed in Detroit over the holiday last year. You didn't fire me as a patient. Instead, you reassured me that you'd be there through the process of getting back into sobriety and recovery. It was then I realized that treatment would only fail if I gave up, and even if I did, you wouldn't. It's with an open heart that I wish to express my gratitude. Simply put, I couldn't have reached this point without your help. You've truly made a difference in my life. I will not waste this chance. Thank you, John, from the bottom of my heart. I still mean this, every word of it. So, thanks.
So I thought you were going to be surprised by the announcement that David is pursuing a nursing degree. And I was surprised by the letter, but pleasantly surprised. It's my privilege and honor to work with you and to work with all the people that we work with at Old Town Recovery Center. So